Okay, good afternoon, everyone. Thanks for joining today. Dr. Hayes and I are here in the room. We have lots of other experts on the call, and just want to give an update to everyone on basically what's going on in the community in Northeast Wisconsin as a whole, and talk about what's going on specifically here at DCMC and all the things that we're doing to try to stay on top of this, and then, of course, just answer any questions that you have. It's been a little while since we've done this in this format. Obviously, we had forums and other opportunities for asking questions, but it has been a while since we've done it in this format. So just a reminder, everybody's on mute by default just because of the number of participants we have. Right now, we're up to about 87 participants. So if you want to bring yourself off of mute, feel free to jump in and ask any questions that you have. Otherwise, if you want to type your questions into the chat, I will be monitoring the chat and can ask those questions, read those off, and ask those as well. So whatever works best for you is fine with us. And again, appreciate you joining in, and we'll go ahead and get started today. So we'll start how we start every incident command meeting with me asking Dr. Hayes for a situation update.
Situation update. So I think for everyone, the biggest piece of information is we've been busier. We currently have, I think we're down to 3 patients in the Cove, which is what we call the COVID unit. We discharged a couple today, so we were running on about 4 or 5. The maximum we had was 6 that happened last Thursday afternoon. So we've had, people have been doing fairly well. We've been doing the usual treatment. But overall, things have been busy. Testing center has been quite busy. Thankfully, over the last couple of days, we've had a little bit of a reprieve on some positives, not quite so many. So I want to make sure it's not muted. It's not.
We're getting notice from Tree that she can't hear us. Can somebody else either come off mute or let us know if you can hear us?
Can hear you just fine.
Okay.
Okay, good.
Thanks.
Oh, I thought someone said, I can't bear you. It's like, yeah, I know, I hear that all the time.
Wait, how'd my wife get on?
That's right, that's right. So I think, as an organization, I think we're doing well. I think most of us are stretched to the max. And so, I think we all share each other's, burden in that sense. But just to give you sort of an idea, too, of what's happening regionally, Brian and I were on, and I think Beth Resch was on a phone call this morning, which we're doing once again, twice a week. And in Green Bay, they have 120 hospitalized patients amongst all the hospitals. All the hospitals in Green Bay are either at or very near capacity. My understanding from this morning was that all hospitals in the valley, in the Fox Valley, were at capacity. So we really are sort of in the epicenter of the nation as far as new positives and new cases and increased hospitalizations. So, for me, I just keep waiting for the shoe to drop. I mean, we had our surge, which thankfully was short-lived last week, and we really felt it because even with only 6 people, you really feel it, in a hospital our size. And just need to shout out to everyone that the housekeepers and the house supervision and others that were involved with those, because everyone just does a great job, and it's great to be able to work at a place like this where we all are family and help each other out. So that's my update.
All right. The other thing that's kind of just in terms of breaking news, the governor did come out with another emergency order today. So if you haven't seen that yet, the governor is restricting gatherings in indoor settings to 25% of the capacity of any given, I guess that's room or building. I've not read the fine detail on that order, but I'm sure we'll hear more in coming days. I was just talking to Dr. Hayes about it before we jumped on, and I thought, like my initial thought was to restaurants and things like that, but we need to be thinking about that in terms of our facility as well. So if we have meetings that are taking place in conference rooms, we need to be thinking about, are we over 25% of that conference room? And if we are, we need to come up with a different solution. So there are things we'll need to think about as well with that new order from the governor, and try to comply with that as best we can. So it's just always new stuff. It's just, something new every day. And we really are, like Dr. Hyde said, if you look at the New York Times is the one I look at, they have a really good website that kind of tracks cases per 100,000 residents throughout the country. And not only is Wisconsin, and specifically Northeast Wisconsin, the hardest hit area on their national map, but also they show counties that have been hit particularly hard, and there's several counties that show up in Wisconsin, including Kewaunee. Now, fortunately, we're not on their top, whatever it is, 20 or 30 top counties that are hit the hardest. We're not on that list yet as Door County, but Kewaunee County is, and certainly all the county, actually Brown County is as well. So all of them right around us certainly are. So that's the situation that we're in right now. You go ahead and feel free to start asking some questions, whatever questions that you have. I've got some topics that we can talk about to fill time, but would love to hear from you and want to make sure we're talking about what you want to talk about. So the first question that came in is, so what does this mean for our clinic? Will the waiting room be limited to how many people can be in that area? So again, this is a good question. I don't know.
I think we'll have to see. I mean, I think if we continue the physical distancing thing, the 6 feet apart, and we're requiring masks. I know the last time when there was some limitations when restaurants and things were closed in the spring. As I remember correctly, it didn't necessarily apply to places like ours, but we'll have to look at those details and see. But it just seems to me that if we stick with the 6 feet plus distance, I think we'll be okay. But more to come on that.
Yeah, I think it's kind of a good idea. I mean, we've already done a lot of that, of thinning out our waiting rooms and making sure we have them spaced appropriately, but we should probably look and see if we have actual capacity numbers on our waiting rooms. Legally, I'm not sure if we do, if that's part of the design or not. So we'll look into that. It's a good question. All right. Other questions that you have, feel free to submit them. I wanted to put in a plug for flu vaccines. I know we've had flu clinics start now, and we keep hearing over and over again, that's going to be a particularly important part of combating the spread of COVID-19 in our community, is making sure that we also combat the spread of flu, because the more patients and employees we have who are experiencing flu-like symptoms, obviously we have to jump through all the hoops of trying to figure out, is it COVID-19? That ties up resources. It could potentially sideline you until you get test results, all of those sorts of things. So we know as employees, it's essentially mandatory to have a flu shot, and that's great. But we also want to be encouraging others in the community to get their flu shots this year. So anything you'd add?
No, I think that's spot on.
Okay. Another topic of conversation is testing in our skilled nursing facility. That is the one area of our facility where we are mandated to test all employees on occasion. Right now, because of the high level of COVID in Northeast Wisconsin, I believe we're mandated to do testing twice a week. And I understand that we just received testing supplies from the federal government to help us do that for our skilled nursing facility employees. And I think that includes not only the full-time skilled nursing facility employees, but also folks who come into the skilled nursing facility, like deliver food or help with environmental services or whatever the case may be. So I see Judy Simmons, I see that you're on the call. I don't know if you want to bring yourself off mute and talk a little bit more about that. And not to put you on the spot, you don't have to, but if anybody has other questions about that, what we're doing in the skilled nursing facility, please feel free to ask on that.
This is Nancy. I can speak to it.
Sounds good. Thanks, Nancy.
So we did get testing supplies. These are supplies that were actually from the state. We haven't received our supplies from the feds yet.
Okay.
The frequency of testing is based on what's going on in the community. The community tells us that right now we should be testing once a week. However, because we've had positive staff, we are on outbreak protocol, which means we should be testing twice a week. And that means residents and staff. But because we are not able to secure testing supplies to do the twice a week testing right now, we're only doing it once a week. The state expects that by the middle of the month, they will be able to supply all the nursing homes with enough tests to do the twice-a-week testing.
Sounds good. Thanks, Nancy.
Mhm.
So in terms of testing for all other employees, that's really been just based on, if you're experiencing symptoms or if an investigation has indicated that you might be a close contact and those sorts of situations are really the only other situations that we're testing employees at this point. So another question came in, can you speak to the process for testing for flu and or COVID specifically in the clinic? Like, I guess, how will they know what to test for and what's available?
Yeah, so I think we're right now working through what we're going to do as far as that testing is concerned. We've got a couple of new instruments that are going to be coming online and a couple that are existing already. So as an example, last year we were using, you might have heard us talk about our Cepheid analyzer. If I'm not mistaken, and Jane can come on and correct me if I'm wrong, our Cepheid analyzer is what we've been testing flu with. And now we're using it for our COVIDs. That's sort of what we call our rapid test. So there will be tests available on that device as well as a few others that are able to give us a panel that'll give us influenza A, influenza B, and COVID, and sometimes RSV as well. So I just had an initial meeting today with Dr. Murphy from pathology and Jane about how we can start coming up with protocols for that situation. So if someone's in the clinic and they have respiratory symptoms, which test should we use? It seems pretty clear that we'll end up using one of the combos because we're going to want to know if someone has respiratory symptoms, we won't know what it is. If it's flu or RSV or COVID, we really don't know. And so many of the people that I've talked to on the phone when I've called positives, they have symptoms that were it not for COVID, we really wouldn't think anything of it. We might think that they have a cold or they have just a viral upper respiratory infection. So, that may be a long-winded answer to your question, but we will be talking through what's the process going to be. It'll be, I think, in as far as execution, similar to what we've done in the past as far as swabbing patients and things like that, but we'll just be using perhaps different devices to get the results we're looking for. Hope that answers that question.
Good. And then just in general on testing, I know there's always a lot of questions around testing, and I did double check with some folks at the testing site in our lab just within the last hour just to see how things were going, and we are still attempting to test as many people with our in-house equipment as possible. We're trying not to send tests out to Exact Sciences. One of the only times that we've had to send tests out recently is when our T2 analyzer, which is the one that we rely pretty heavily on for COVID testing, when that goes down, obviously, then we have to send out tests. So right now, the T2 analyzer is up, it's running. We have a backlog of about 80 tests on that analyzer right now. They can typically, if the positivity rate is low enough, they can get through 80 to 100 or so in a 24-hour period. So we're at a less than a 24-hour turnaround time right now. However, in the last few days, we did have to send out about 135 tests to Exact Sciences during short time periods when the T2 analyzer was not available. So we still have that mix of some tests going out for results and other tests we're processing in-house. And again, that it creates inconsistency in the community. So you'll hear community members say, how come my neighbor got their test result in 24 hours and it took me 7 days? And that inconsistency is unfortunate, but in reality, what our lab team is doing is anytime our internal analyzer is available, they're using it, to the extent that they can, so that we're trying to get the fastest turnaround times possible, and only in those times when it's not available are we sending out. So.
Yeah, I don't want to oversell it, but I think that probably within the next maybe 3-4 weeks, by the end of October, let's say, I think we're going to have ways that we're going to be able to do virtually everything in-house. Different, there's different modalities out there. There's the PCR test that we are currently doing. There's another test called antigen testing that we already have the device in-house. We're just getting set up for that. And there's reasons why we would use that versus something else. And so I really expect that by the end of the month, we should be able to do virtually everything in-house. And I'll just throw out a plug, just as everyone here is an ambassador of the organization. Every once in a while you get some of these rumors that start spreading. And when we talk about the T2 analyzer going down, if anyone in the community says to you, I heard you can't test at the hospital, I'm sure most people know this, but we can always test. There's never a situation where it would be down and we couldn't test. That was a rumor that was on WDOR a couple of weeks ago, I think. But we couldn't possibly, we couldn't do any tests. So I think it's important for people to know that we can always test.
All right, the next question that came in, regionally, has there been any analysis as to why Wisconsin is peaking the way that it is? And I pulled up an article from the Wisconsin State Journal that came out a couple of days ago, but honestly, this is by an economist. I was an economics major, but I'm not sure you want to hear my analysis on
Not
why
really.
on why COVID is peaking. So I'm not sure why this economist is any more qualified. So I've not heard anything definitive that really explains it. Have you?
That was pretty good for an economist, I have to say. That wasn't bad. My wife's was an economy minor, and so she.
Yeah.
No, I don't think that there is any analysis. All I can tell you is that what I have heard, I've heard it said, at least in northeastern Wisconsin, our region, and certainly locally too, is that a lot of the outbreaks that we've seen can be attributed back to large gatherings. So whether it be a wedding or a family reunion or something like that, that seems to be kind of the culprit. Now, why is it just us? I don't really know.
Yeah. Here's the explanation from the economist at the Wisconsin State Journal, if it, for what it's worth. One, he said, Wisconsin's a divided political state where too many people have shunned masks for the wrong reasons. So he thinks just, the political environment and people not complying with the precautions is one reason. The second reason he said is that they believe that Wisconsinites may be doing what their ancestors did during the Prohibition era in the early 20th century and moving their drinking and socializing underground. He believes that a lot of gatherings are still taking place, just not in bars and areas where you would have seen them in the past. And then the third thing is the weather's starting to turn in Wisconsin, which means more people will be spending more time inside. I mean, I think all of those are valid guesses, but I really don't think we know, and I'm not seeing anything nationally or regionally that gives any really definitive good reason.
Yeah.
So, going back to testing for just a minute, I know we made a change last week, or was it early this week? I'm confused now. I think it was last week when we started delivering all negative test results via the portal.
Yeah.
And any thoughts on how that's going? Are you hearing anything?
I really haven't heard a thing. So hopefully it's going well. It definitely decreases the amount of time that staff have to be on the phone, which is a good thing. I know in Green Bay, it sounds like Purveya is using the portal for all results, be it positive or negative. We're still in a position where we can manage to call, and I kind of like the personal touch of being able to call somebody. So as long as we can continue to handle that, we'll keep doing that.
That's good. I know Eric Schreier said this morning that certainly our number of portal users has gone way up. I think it's been, 150 new users in the last week or something like that. And I can't remember if he said 500 new users since July 1st on the portal. And that's about as many as we had in the whole previous year as new users. So we're definitely seeing a lot more people going to the portal for results. And I think that hopefully is one of those things that'll serve us well going forward, to have more people, just more of our patients on the portal in general. I know Nancy Davis also put out something today about printed COVID-19 results. There are a variety of reasons that our patients need printed COVID-19 test results. Sometimes their workplace requires it, sometimes their school requires it, whatever the case may be. And she put out a document today that shows all the different ways that a patient can get printed results. One is via the portal, so they can go on the portal and get their result and just print it out from there. We can also email a copy, mail it. Both of those things can be done by contacting the HIM department. HIM department can also coordinate an in-person pickup, but obviously they request that positive COVID-19 patients do not come in for an in-person pickup of their results. That's actually happened, or it's been attempted so far. So we laugh a little bit at something like that, but we have had positive patients who have tried to come in to pick up a copy of their results. So anyway, just know that that's out there, and our HIM team is willing to help and work with anybody who needs a printed copy of their results to make sure that we can do that. All right, next question. Is the COVID, let's see, so is the COVID test a result that pushes to the portal right away, or is there a 24-hour wait as there is with other results? I think for COVID, we've got it down to 2 hours.
2 hours, yeah. So both positive and negative get there within 2 hours. So we try to call the positives within 2 hours, but they're there.
Yep. And Cindy says, shout out to the HIM, the folks who deal with getting people on the portal so that they can see their results. Absolutely. That's been a great thing to be able to get people on and have access to that. While we're waiting, and while we're talking about testing, another thing we're looking at is kind of winterization of our testing operation. I don't really have any definitive announcements today on that, but we're looking at a lot of different options. We know that having our staff go out to car windows and do the test through the car window is still fine right now, especially today, as nice as the weather is, but in a couple of months, that's going to become unbearable. So we are looking at other solutions that involve possible construction on that education building. That's one option we're looking into, and we're looking at just, configuring some of our clinics and staffing in different ways too, but nothing definitive on that. We're still just looking at all the options. So. Let's see. So another thing that I wanted to bring up that people might have questions about, and you alluded to this, Jim, we've got other testing modalities that are going to be coming on, new analyzers and different types of tests. One of those is an antigen test. So do you want to talk about what an antigen test is and how we might use it?
Yeah, so an antigen test is, an antigen basically is the offending bug, let's say. So we talk about antigens, which is the virus, the organism. An antibody is what the body creates to fight off that antigen. So the antigen tests are typically, some people, I've heard them referred to as spit tests, and basically what it is you would take a swab, and usually just in the mouth and the cheek, you would swab there. And again, if I'm incorrect, Jane can certainly hop on. And it's run in that analyzer, and we're able to get a positive or negative test in pretty quick order. I think it generally is about 15 minutes or so. Those tests, when they first came out early on in this, they weren't very good. You really couldn't necessarily believe the results. But as the technology has improved in the short number of months that we've gone through, even though it feels like 10 years, it's only been 7, 8 months that we've been dealing with this. The sensitivity of those tests is much better. There's been a lot of research and studies about how to use the tests. And so as a great example, what might be a great time to use it is if someone comes into the ER, or let's say they come into clinic and they have symptoms, respiratory symptoms that might be COVID, and we want to rule it out. If they're pretty good symptoms, they got a cough, let's say, or they lose their taste and smell, and we do the antigen test and it comes back positive, we can believe that test. So that's kind of the context that it would be used in. So I don't know, I don't know that, like if Brian and I were to right now do one of those and run it, if it came back negative, could we be certain that we're negative? Not necessarily. In some cases, the recommendation is to back up that negative antigen test with the other stuff, the PCR test that we're doing. I'm trying to avoid throwing around too many words and acronyms. So I think it's going to be a really good tool. And I know, for example, the Dorchester right now, they have their own antigen test and they're doing it. I'm not sure what their regimen is or how they go about doing it. But I think it'll be a really good addition. I think we'll be able to rule in or out important groups of people pretty quickly. And that should take away some of the burden for the PCR tests as well. And the other thing to this, as we mentioned a little earlier, is these combination tests. Because right now, if someone came in and they said to me, I have fever, I got a cough, I have really bad body aches, and I feel terrible. Well, that could be COVID very easily. It could also be influenza. You know, we're coming into that season, and the symptoms can be really identical. And in some other ways, it could be respiratory syncytial virus, RSV. So these panel tests that we can run, and it tells us boom, 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 whether it's there or not, it's going to be really helpful for us to sort this out, because I think that's our big fear, and I mean fear in air quotes. You know, big fear going forward is we're going to have people coming in here with all manner of respiratory symptoms, and we need to sort through that pretty quickly as to, well, what is it? Is it viral, meaning just nothing? Is it a cold? Is it COVID? Is it influenza? What is it?
Yep. I think the only other announcement I have on testing is that we are continuously in contact with the county, and they have invited the National Guard to come back and do another kind of mass community testing. So I don't have a date on that yet, but we're still hopeful that that'll occur. In fact, they've asked the Guard to come in every other week for a while, so that they're doing one of those every other week. So when we hear more about that, we'll certainly get that information out to everybody. It's always a good opportunity for us, you know, as employees too, if we want to be tested. So let's see, we got a question coming through here. I'll let you read that.
Okay. Someone has a question about what would be the PPE expectations for staff members who have had COVID. Generally speaking, you know, if you've tested positive for COVID, you have that 10-day quarantine period from when you begin, from when the first symptoms start, or if you're a close contact from when you have the test. So there's 10 days, that day of first symptoms, close contact, or I'm sorry, test is day 0. 10 days from that, you're out of quarantine, assuming that you have no fever that's reduced by any medication. So no fever, symptoms are better. There's really no data that I'm aware of that says you need to be in any more PPE than what we're using right now. So a normal surgical mask, things like that. So you aren't Typhoid Mary coming back after you've been through the quarantine period. And the reason for that is because that's how the virus works, basically, is that by that time, the infectivity period has certainly lapsed, because it basically is anywhere from 5 to 14 days. You may have symptoms, it's infective over that amount of time, and then it moves on or goes away. So there shouldn't be any cause for any other PPE beyond that.
All right, the next question that came in is regarding the visitor policy. So I want to take a minute and talk about that. We did just do an update to our visitor policy. It would have been on Friday that we pushed that out. And so here it is on the screen. Basically, it's essentially a no visitor policy, but of course there are exceptions. So visitors to the hospital will not be allowed, except for obstetrical patients may have one support person. Pediatric patients younger than 18 may have one parent or guardian present. Patients who are nearing the end of life, we make special arrangements with the families for those circumstances, because we know how important that is. So those exceptions do occur. Patients having emergency surgery may also have a support person, and then those seeking emergency care may have a support person as well. In general, in the clinic, we try not to have any visitors. However, we know that there are some patients who need assistance, and so if it is someone who needs assistance, then they can have a support person with them as well. Skilled nursing facility, we're still really trying to restrict visitors to the skilled nursing facility. The only types of visitors that are occurring at this time are prearranged courtyard visits and compassionate care visits for end-of-life situations. So those are the general updates on that. I don't know if there are any specific questions about that, or if it was just a general question about that. And then at what point will we start testing hospital or clinic staff on a regular basis?
I don't know the answer to that, to be honest. I don't know that we would get to that point. I know you hear you hear other, you know, at the NBA bubble at Disney, they were testing all the time and things like that. I'm not sure if we would get to that point, and I'm not sure what would be the signal to do that. It's a good question, though. I think in an ideal circumstance, I know Brian and I had read an article from the Atlantic, and that's one of the things they kind of talked about was, you know, in an ideal world, if they have really cheap tests like a pregnancy test, home pregnancy test, where everybody every morning could check, that might not be a bad idea. I don't think we're there yet, and I don't feel like I know enough to be able to speak intelligently to whether or not that would be a good strategy or not. Not to throw any politics in this, because that's not my intent. It always bothers me when I hear talk of what's going on in the White House, that, well, we don't have to wear masks because we test every day. And that, to me, misses a huge piece of this. I mean, just because you tested negative doesn't mean you can't test positive, you can't get the infection from someone else. So, sorry for the lack of answer.
Yeah, I think, I mean, some of the tests that are coming out that are a little bit more rapid and easier to use, like saliva or whatever the case may be, they're also pretty inaccurate. And so
that's the worry.
So that's the challenge, is we could start some kind of mass testing with our employees, but you know, you run, if you have false positives or false negatives or whatever the case may be, then you've got to set up a whole nother process for how to deal with that.
Right.
So I just don't think we're at the point where we have a test that's readily available that we trust enough to do that. Right.
And the only reason that you do that is because, you know, unlike influenza, you know, if you don't have symptoms, you don't have influenza, whereas here you can have it before. The problem too is that you can have no symptoms at all and never have symptoms at all and still be positive for COVID. So, but we also don't understand at this point whether or not people that have no symptoms at all, if in fact it truly is, even if they're contagious. And so there's so many questions. So it's not an easy answer, unfortunately.
Yep. Question came in about travel restrictions. Some businesses are enforcing travel restrictions. If you sleep in any other bed than yours, you're required to quarantine. Do you anticipate that happening for our staff? You know, we talked about that. We did a little bit of that back in the spring, where we were at least tracking staff travel and those who were going on spring break and summer trips and those sorts of things. We were kind of trying to keep track of and monitoring those folks when they came back. But my take on this, and I think you feel the same way based on some of our discussions, unless, you know, this recent outbreak has changed anything, but I think the same precautions you take here at home, you can take on the road. Mm-hmm. And so I think in general, you know, I don't think that there needs to be any kind of travel restrictions, but we all do need to be responsible. And so whether you're, you know, traveling down the road or to the store, or whether you're traveling across the country for some reason, you know, to help with a family emergency or something like that, we all do need to be sure that we're taking as many precautions as possible.
I think that's absolutely true. I mean, it's kind of, I don't know if I'm just too much of a simpleton, but you look at as Brian said, you look at the map of where the hot spot is, we're it. So it's like, I don't know how you could do much worse traveling anywhere else at this point. So I think if you stay safe and wear the mask and try and stay distant, I think you'll be fine.
Okay. And this question came in, I think, regarding the last Facebook Live. It says, if I understand correctly, public health recommends that if you've been notified as a close contact of a COVID positive person, you should quarantine for 14 days, even with a negative test. It seems like if that is true, every healthcare worker would be permanently quarantined and we would have nobody staffing the medical center. Clarification, please.
Yeah, so again, the definition of a close contact is someone that has tested, if someone has tested positive and you, as a close contact, if you've been within 6 feet of that person for 15 minutes, either at one time or over the course of a day, you are a close contact. You then need to quarantine for 14 days, and that 14 days starts from the last time you've been with that person. It doesn't affect all of us right away, because most of us, you know, generally speaking, when someone is positive, it's a fairly close cadre of people, so it's not everybody that would happen to. Also, because we're in healthcare, we understand the importance of quarantining, we understand the importance of symptoms, and so what we've done is, for people that are in healthcare, like myself as an example, we will work even as a close contact, wearing all the appropriate masks. You don't need to wear an N95. This is all appropriate. But then when we go home, we're expected to quarantine as though we were in full quarantine, so to speak. Hope that helps.
Yeah, you did not mishear that comment. I mean, that is the recommendation, is that a close contact should quarantine for 14 days, even with a negative test. But
Yeah, the test is sort of not relevant. I mean, you still should get it. The recommendation is you get tested 7 days after the person that you've been exposed to. But even if it's a negative test, it doesn't absolve you, because you could become positive all the way up to the end of that 14 days.
mm-hmm. And then a follow-up question to that is, does that change with masking? I'm thinking of rehab where we're routinely in small rooms with someone for 45 minutes at a time, and actually
No. Masking does not change that at all. And that was one of the things, really, with all transparency, that was one of the things when that came out, a lot of us were really frustrated about, because we're sort of like, well, we're trying to talk about wearing a mask and how appropriate that is and advocate for that. And then you tell me that, well, if I'm around someone that's got COVID, my mask didn't help me. And the reality is that last sentence is not accurate, that it didn't help you. Yes, it does help you. You can still, these masks are not perfect. No one has ever said they are. You can get COVID through them. But one of the things I think is pretty clear, I don't want to say we know it to be true, but I think studies will bear out that what we're getting is far less inoculum. We're getting far less virus in through these masks. And so even if we are exposed, if we do get it, we're getting way less. And the way less translates to much less severe disease, in fact, very mild disease.
Now, I will say, because I know, Amanda, I know you're asking from a rehab perspective, and I think this would be true of anybody who works at DCMC. You know, we do come in contact with positives, right? I mean, that it's very likely that the scenario that you're suggesting, where you have a patient in rehab and then the next day they test positive, and so public health is going to call or in theory would call you as a close contact. But I will say public health has given, I don't know if leeway would be the right word, to healthcare workers, or they just kind of have a different standard for us as healthcare workers. So, because I think it's because they trust that we know the importance of the PPE, we know the importance of hand hygiene, and that we're following all those precautions, they're going to treat us differently than they would, another business that they were investigating, or kind of another setting in the community. So it is still our standard. As public health works with our employee health folks, it is still our standard that if an employee comes in contact with a patient who's positive, and that employee is wearing the mask the whole time and following hand hygiene and all the precautions that they need to take, then they're still not deemed a close contact.
Correct.
As a healthcare worker, but that wouldn't be the case in any other setting in the community. So I know it's confusing. It is a double standard, but in this case, it's a double standard that we appreciate, because we do, well, one, we appreciate that they acknowledge that healthcare workers do have a better understanding of all of this, but two, we've not seen any evidence of spread from patients to employees or anything like that. So we do think that the precautions that we're taking certainly are working here at DCMC.
Well, we require our patients to wear masks, right? And so you're required to wear a mask as an employee. The patients are required to wear a mask. There are studies that have shown that if both the person with whom you're working is wearing a mask and you're wearing a mask, your chances of getting infected through those two barriers is really, really small. So that helps.
While we're waiting for the next question to come in, just to talk a little bit about community events. I know that one that's kind of been on the radar screen for us has been the Fall 50, because traditionally we have staff who are involved in helping out with the Fall 50, and we also have staff who participate in the Fall 50. So that's one we've had on the radar screen. They did announce today, I saw it on Door County Daily News, that they have canceled the Fall 50. And that's one of those, just personally, I wasn't going to do it this year, but personally, I was hoping that could go on, because of all the events you can think of, spreading runners out over a 50-mile course seems pretty safe. But again, there are still concerns at the starting point, at the transition point, at the finish line, where you could potentially have large groups of people gathering together. And in the end, with the outbreak that we're experiencing, it just didn't make sense to do something like that. So that has been canceled. Any other community events or things that you're hearing about that?
No, I'm not, I mean, we all know that the festivals are not happening. That's not,
Right.
that's old news.
Yep.
Beyond that, I haven't heard anything new.
Yeah, so I think, you know, the community's, I don't want to say shut down, because I think we're doing everything we can to avoid shutting down, but definitely the community continues to be more and more cautious until we start to see our numbers turn around. And we have seen, I will say this, you know, as a leading indicator, I always use testing demand, because when we see the testing demand go up, we tend to see a spike in positive cases, and when we see testing demand drop off a little bit, then things start to quiet down a little bit. Last week, we had a couple of days where the testing demand was lighter. Today, testing demand was a little bit lighter. So I think those are good, positive signs, and, you know, you can't hang your hat on it, but hopefully we're starting to see the end of this spike anyway.
It'd be nice.
Yep. All right, trick-or-treating. Question about trick-or-treating. I've heard it's on.
Yeah, I've heard it's on too. I don't,
Yeah. I don't know the rationale for that. I don't know. I mean, okay, one thing I'll ask you though, is there is a lot of evidence now that COVID is not spread on surfaces as much as we once feared that it was.
Yeah, no. Yeah, that's the least of it as far as I'm concerned. I mean, you know, from the get-go, I remember a Johns Hopkins study early on that talked about 0.1% of the COVID cases are as a result of contact, where you touch something and then you don't wash your hands and you touch your face and you get it that way. So this really is a respiratory thing. And so I think trick-or-treating, I mean, it's always hard to say, because you can come up with scenarios for anything. But if you're staying away from, if you're walking together but you're staying 6 feet apart, you're wearing a mask, you're outside, it's probably okay. It's always those that's where it falls down, because, you know, we all know, you get kids together and it's impossible to stay 6 feet apart. You just can't even tell them to do it, because they won't. Kids are not as high of a risk as adults or people with comorbidities, so we're sort of less concerned about that, I guess. I really don't remember what I think they are having it, but I haven't heard.
Yeah, I would say stay tuned on that, because that could be one of those
things
like
change.
the fall 50. You get a couple of weeks upon it, and people might have a different attitude.
You know, my advice in general for people, you know, and certainly as employees is, you know, I think we know enough about this now where, you know, I think if you're going to go somewhere, let's say you're going to go, although it sounds like eating in a restaurant is going to be curtailed based on the governor's thing, but even stores, I mean, if you go into stores and you see that the proprietor of the store or whatever, or most of the people in the store are not wearing masks, despite the order, I mean, whether you agree with the governor or not, it's still, that's what the rule is. If you go into a store and you see a lot of that, my recommendation is turn around and leave. Only because I think a little bit of peer pressure helps in some of these matters. We understand that in, you know, congregate settings and, you know, close, tight spaces in smaller stores with people without wearing masks, that's where you get infected. And I'm here to tell you, as someone whose son was a close contact at school, he tested positive. Thankfully, my wife and I didn't test positive at all. But we weren't really worried about that, but it is a pain. It is an absolute pain to be in quarantine it's 14 days, by the way, it's 14 days after the last time you are with that person. When they live with you, it's after their quarantine is up. So my wife and I technically are still right now in quarantine till the 12th of October. Now we feel like we've been in quarantine for a month. So it's a pain. And so if for no other reason, just being purely pragmatic, I think kind of leaving a business where they choose not to wear masks, I've developed a lack of patience for that. And you know, you can go somewhere else and spend your money. So that's my 2 cents.
Yeah. Good question came in here about temperature taking at rehab, and should temps be taken at every entrance place. So this is something that we've looked at in all different directions, and we've kind of arrived at this situation where we do have inconsistency, but I think it's okay to have inconsistency in this case. So right now, my understanding is at rehab, certainly at the Cherry Point location, we're still taking temps before we're bringing folks back for their rehab. We're not taking temps, I don't believe, in any other location in the hospital. The reason or in the clinics. The reason we decided that is because most patients who come in who have a need you know, who are ill are going to have their temperature taken as a part of their visit here, whether that's in the ER or the clinic or any other area. If a patient's going to rehab, that's not necessarily a standard part of the process. And so if that is something that the rehab team has felt like they need to do in terms of temperature taking, we've definitely supported that. And it looks like from this question, you know, there definitely has been, there have been people who have been identified, patients who have been identified as needing to go home and not have their rehab that day based on the temperature taking. So based on that, I would say, you know, absolutely continue to do it. Whether you're doing it at the door or at the time that you would bring the patient back, I don't know that it matters a whole lot as long as we're not crowding people into a waiting room, and I don't believe that we are. But we do have inconsistency right now in regards to that, in that some, you know, like I say, the rehab area, they are doing it. Other areas, we're doing it in the exam room.
Yeah.
So.
And the reason we stopped doing it generally across the, you know, the organization a while back is that well over 50% of people don't have fever at all. And so it's, if you're looking for that as your security blanket, you're not going to get it because you really don't know. And so that's the main reason why. But as Brian said, certainly if that's a comfort, then, you know, and you do catch the occasional one like that where they have a temp. But also remember that there's lots of things that can cause temps other than COVID as well.
All right. Any other questions? You know, one thing we've talked about a lot in our incident command meetings over the last week, since we've kind of had our, I don't know if you would call it a surge or a mini surge. Last week we had 6 COVID positive inpatients at one time. One of the things we've talked about is our surge plan, and, you know, at what point would it make sense to cancel elective surgeries, or at what point do we need to slow down the clinic operation and those sorts of things. And I'll tell you that all of those things are on the table, and, you know, we're just constantly monitoring the resources needed to take care of the COVID positive patients in the ED and in the inpatient setting. And we know, based on all the cross training that took place back in the spring, we do have folks that we can call on from the clinic and from other areas to help fill some of those roles. And when we need to do that, we'll definitely do it. At this point, I would say by luck more than anything else, the COVID surge of last week and kind of this week has fallen at a time when our overall inpatient volume was a little bit lower. And therefore, we did have the staff and the resources to take care of those folks without having to pull too many people from other areas. So when that's the case, we'll try not to slow down clinic visits. We'll try not to slow down elective surgeries. We know that those things need to continue. Those patients need that care. Otherwise, they wouldn't be on the schedule. Mm-hmm. So we're going to do everything we can to try to keep everything going. So there was a question that came in about elective surgeries. You know, if we were to start to look at that, it would probably be inpatient surgeries that we'd have to look at first, because those are the ones that are most resource intensive for everyone involved. But at this point, we do not feel like that is necessary, and we've not taken that action to cancel any surgeries. Any other questions? Well, thank you for your time today and for tuning in. We had a good group and good questions. And if you're like me, you're probably going to think of another question once we're done here. So I do want to remind you that we do have that frequently asked questions page on the intranet, and you have the opportunity to submit questions at, well, it's been so long since I've said the email address. I think it's covid19@dcmedical.org. So hopefully I said that right. But you have the ability to submit questions to that web address and then get those answers on the FAQ page too. So feel free to continue to take advantage of that. So any closing thoughts?
Well, you know, I was talking with a colleague upstairs in the ICU earlier before this, and we were talking, and we both kind of indicated how we're really tired, you know, in general. And what's hard is the fact that it seems to be that we're tired at a time when we don't see an end to this. And so I think this is one of those things where, you know, and what props me up is being able to work with the very person with whom I had that conversation, because it was, you know, being able to kind of share that, hey, you know, we're doing really the Lord's work, and we really are doing this is what we're made for. This is where we really are practicing during one of the most important and unprecedented times in any of our lives. And so I think that kind of leaning on each other using each other's strengths to get through this is what we need to do. And I have no doubt that we'll do it. But it can be rough. But the joke that I make, I make jokes about everything. I always say, this too shall pass. It may pass like a kidney stone, but it shall pass.
Yeah, I think use the term lean on each other, and just the phrase lean. I mean, that's something I've seen over and over again with all of you, with everybody who works here, is we're all leaning into this experience. I mean, and that's not the case everywhere. There are some folks who, when faced with this kind of struggle over a prolonged period of time, want to throw up their hands and say, there's nothing more we can do. And I'm not seeing that from anybody on our team.
No.
Everybody's leaning in, continuing to know that this is the moment that, as you said, that we were made for in some ways. And so thank you for doing that. Thank you for being there for each other. Continue to lean on each other, as Dr. Hyde said. Question is, employee assistance program still available through Door County Counseling? Absolutely, it is, and we want you to use it. That's probably one of the more underutilized programs, and it's paid for by DCMC. It's prepaid. We want you to use it. So please do reach out to Door County Counseling Associates through our EAP program. If you need information about that, have questions about that, you can definitely contact our employee support and development team, and they can help you in a confidential way, get you the resources that you need. So I think that's it.
That's it.
Thank you very much. Have a great afternoon, everybody.